How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hello, you're listening to DNA Today, a genetics podcast and radio show. I'm your host, Kira Deneen. DNA Today informs you on what's happening in the genetic world. During my broadcast here, I educate you, the public, on genetic and health topics through event coverage, news stories, book movie reviews, and interviews. Guests include genetic counselors like today, researchers, doctors, patient advocates, and professors. So to raise awareness for February being Heart Month, I am joined by Amy Sturm. She's a cardiovascular genetic counselor. She has 15 years of experience in cardiovascular genetics, personalized genomics, research, and education. She's the director of cardiovascular genomic counseling and a professor at Geisinger Health Systems Genomic Medicine Institute. There she provides leadership for the scaling up of genomic counseling efforts in the MyCode Community Health Initiative. She serves as the president-elect and the Cardiovascular Genetics Expert at NSGC, and for those that don't know, that stands for the National Society of Genetic Counselors. Amy also works in the Familial Hypercholesterolemia Foundation and the Sudden Arrhythmia Death Syndromes Foundation on their important advocacy work, research, and medical education programs. So thanks so much for joining me on today's episode.
You're welcome, Kira. Thanks for the invite.
For those that don't know, I want a quick elevator pitch from you of what a genetic counselor does. What are your roles in the field of healthcare?
Sure, absolutely. Well, genetic counselors are really experts in both genetics and counseling, like our name says, and we have specialized training in both the science of genetics, and then we also get training in all of the psychosocial issues and psychology, so that we can really help our patients and our families understand everything about the genetic condition that may be running in their family, and then also adapt to really, living with that genetic condition within themselves, their children, and other family members. So genetic counselors really have many different roles throughout the healthcare spectrum, whether it be working with patients directly or working in genetic testing laboratories or working in public health, and many other settings like research, education, graduate training for genetic counseling students. So really there are so many roles. The field is continually evolving. It's a really, really exciting profession to be a part of. But really all of our work and our focus, I would say at the end of the day, circles back to the patients that we serve.
And what does your job consist of being a genetic counselor that specializes in cardiovascular genetics? You mentioned that there's a lot of different kind of subfields of genetic counseling, and so we try to cover, as much as we can on the show, but what do you do as a cardiovascular genetic counselor?
Sure, absolutely. I've been working in the field of cardiovascular genetic counseling since 2004, so about 14 years, which has been really just an amazing ride over the course of my career working with these patients and their families. And in my former position, where I was at Ohio State, I was really had a lot of different roles, including clinical care. And for years and years, I worked with patients and their families who had or were at risk for hereditary types of heart disease. And, I sat down in thousands of patient sessions over the years, working with these patients and families, understand their risk and what they could do about it to really hopefully prevent what had perhaps happened in their family history before them, or what condition they had been diagnosed with but may be preventable for their children. And now, as the director of cardiovascular genomic counseling at Geisinger, I really help try to bring cardiovascular genomics and genetics in a preventive fashion to our patients at Geisinger, and then all of our patient participants who are a part of our very large MyCode Community Health Initiative, which is a large population-based exome sequencing project where we are proactively returning actionable medical findings to our patient participants. And about half of the list of the returnable conditions we are bringing to patients are for cardiovascular conditions. We also return genetic risk reports for those at risk for cancer and some other inherited diseases. but there's a large focus on cardiovascular genetics, and that was one of the exciting reasons why I chose to take on this new role over the past year.
And it's very exciting to hear that there's just so much research and new information being found within cardiovascular genetics. And just from my exposure of different fields, it seems that it's one of the subfields of genetic counseling that you really have a lot that you can do to prevent. That it's in cancer and in different areas, it's a little bit harder to do, but it seems like the information that you can get from genetic testing, you can do a lot of prevention work.
Yeah, that's absolutely right. For many of the conditions that we counsel patients for, whether it be inherited high cholesterol called familial hypercholesterolemia, or some of the inherited arrhythmias, some of the most important risk reducing actions are actually taking a daily medication. And so there are some things that can be done on a daily basis that, aren't that invasive. If you want to compare it to something like cancer genetics, where patients may even be considering very difficult decisions like having prophylactic or risk preventing surgeries. With some of the cardiovascular genetic conditions we work with, some of the preventive options are really, very well within reach. Hopefully for many patients to be able to integrate them into their daily lives. And so the key is really just finding individuals as young as possible so that we can make sure they are able to have the opportunity to know their risk and then start, really kind of these risk reducing measures at a young age.
And so you mentioned FH as being one of the types of inherited cardiovascular diseases. What others are you looking at in that you have sat with patients and talked about and looked at family history and went through genetic testing for?
Sure. I've counseled a lot of patients over the years with inherited arrhythmia or rhythm disorder syndromes. And so these are conditions like long QT syndrome, Brugada syndrome, some of the types of cardiomyopathies, which are heart muscle disorders that can cause abnormal heart rhythms and heart failure. So those are really, a large bulk of the types of patients that I worked with over the years. And so it was really wonderful over the years to integrate and work directly hand in hand with cardiologists and nurses, where we worked in clinics in a multidisciplinary format where patients were able to meet with me as a genetic counselor and meet with their expert cardiologist and nurses to kind of bring this multi-dimensional care to them, where we all were, bringing our own unique expertise at the end of the day to hopefully help them and their relatives reduce their risk of heart disease.
And it's very exciting to actually have like a whole team, as you're saying, of, not just meeting with, a cardiologist or just meeting with genetic counselor, to have all of your different kind of medical backgrounds to bring together to really have patient care be top notch.
Absolutely. You asked me in the beginning, what does a genetic counselor do? And one of the major things I think genetic counselors do really well is collaborate with other healthcare providers and work directly with other healthcare providers. And there's been some work by some of the cardiovascular genetic counselor leaders in our field to show how this multidisciplinary approach, also even including specialists like psychologists and psychiatrists, can really be what's most beneficial for the patient and for the families.
Because genetic counselors really have a lot of skills in different areas of kind of bringing it all together and being that kind of guidance counselor of, for the patients, but also for the other healthcare providers to kind of bring everybody together.
That's totally right. I've had patients actually describe me as a navigator, as a tour guide, as a care coordinator, just what you're saying, that person who really helps bring it all together and who also really knows all the, family dynamics and can help hopefully make the outcome for the entire family the best possible.
And the genetics, the cardiovascular diseases that we're mentioning, how frequent are they in the population? Is this something that's fairly rare or really common?
If you look at all of the different cardiovascular genetic conditions together, so thinking about familial hypercholesterolemia, which is estimated to be as common as 1 in 250 people. And then if you bring in some conditions like the cardiomyopathies I was mentioning earlier, these heart muscle disorders that can lead toward rhythm disorders, heart failure, some of those are even also as common as 1 in 250 to 1 in 300 individuals. And then if you also add in some of the hereditary arrhythmias and hereditary aneurysm syndromes, really you're looking collectively that these conditions are likely more common than 1 in every 100 people. So if you think about your neighborhood, or you think about your Facebook friends, you likely know multiple people with potential hereditary cardiovascular conditions. So they really are more common than may be thought.
And that makes it really important for people to know the red flags of in a family history of what could potentially lead to findings of having an inherited cardiovascular disorder. What are some of these red flags that you go over with patients, and that when you hear it, you make a note in their family tree or pedigree?
Absolutely. One of the top things I always have shared when I'm, speaking with potential patients of mine or giving community talks is that the number one red flag to me is early age of onset. Even if you just have one relatively close relative, so, a parent, an aunt or uncle, a sister or brother, a child who has had a young age of diagnosis of heart disease. And by young, usually we kind of put that in the under 50 years of age category. Because, heart disease, it just should not be happening in young individuals. It typically would be a disease that is very common, and age is a risk factor. But if you see heart disease in particularly young people, that is a major red flag. And so this would be an early onset heart attack, an arrhythmia diagnosed at a young age, heart failure diagnosed at a young age, aneurysms, the bulging of the arteries in our bodies diagnosed at a young age. All of that would be considered a red flag. There's kind of a list I keep in my mind of other red flags too. So early age of onset. Another red flag is if there is a sudden death in a family. And unfortunately, I've met with too many families over the years where a sudden death was the first presenting sign of the inherited disorder in their family. And this can affect children and adolescents and younger individuals in their 20s and 30s and 40s too. So if you see a young, sudden death, that is really a really important red flag to pay attention to. Sometimes autopsies can give some more information about why that death may have happened. But even if it's a sudden unexplained death, that also could be cardiac in nature and something really important to point out to your doctor or a genetic counselor as a red flag in your family history.
And as you said, knowing about these red flags in your family can then bring you to see a genetic counselor, and you guys really encourage that. And once a family or a patient is at a genetic counseling meeting, you do something called Cascade Screening. Can you explain what this is?
Absolutely. Cascade screening is so important because it's really the process that gives us the opportunity to identify all of the other at-risk relatives in the family who may benefit from the knowledge and who may benefit from the risk-reducing medications or procedures or clinical screening. So really what happens is, oftentimes the patient I would be seeing in clinic would be someone who had already been diagnosed with the heart disease. And we would sit down with that individual to go through the clinical genetic testing process. And if the genetic testing process in that affected family member is able to figure out the exact DNA mutation that is causing the heart disease in them, we have gotten a very useful piece of information in that patient. And what we would do is in a cascade screening process, and what this means is in a stepwise, systematic kind of waterfall or cascade effect through the family, we would start testing that person's close relatives. So mom and dad, brother and sister, children. and we would see, okay, who out of these close, what we call first-degree relatives, may also have this mutation. Then when we find it in those close relatives, we then cascade out to the next branch, which we would call second-degree relatives, to see do they test positive or negative for the mutation. So cascade testing or screening is a very important process to figure out who did or did not inherit the gene mutation in a family. And then for those who did inherit the gene mutation, we know we want to plug them into the proper cardiovascular screening and treatment that they may need and prevention. For those who did not inherit the mutation, unless they have any further symptoms or signs, we feel confident that they do not require the additional screening and medications, and also that their children would not be at increased risk. So it's really, really useful information. And I'd also make a point that even if our patient's genetic testing isn't informative, so maybe it doesn't find the answer, we would still want to proceed with what we call cascade clinical screening. So cascade screening can take the form of both a genetic test, but also a clinical cardiology test. Because if we don't have the capability with our current genetic testing technology to find out the underlying genetic cause in every single patient, we still can screen at-risk relatives with clinical tests like an electrocardiogram, an echocardiogram, which is an ultrasound of the heart, cardiac MRIs, or whatever test may be needed with whatever condition is running in that family to be able to find it.
So this is a really, really powerful method and great way of really establishing that you're starting with the patient that has maybe a symptom or has had a heart attack or something, and then you're kind of branching out from there and seeing who may have that specific genetic mutation. So, and interesting that I didn't know that you also do the clinical testing. And is that the case often when you can't find a genetic mutation that you'll move on to that clinical testing?
That's exactly right. It really needs to be done hand in hand also for certain patients. But for some conditions like long QT syndrome, we have very, very good detection rate with genetic testing. About 75% of patients with long QT syndrome, we can find the reason why on a genetic test. But for other conditions like hereditary aneurysms, the genetic testing technology we have right now, it really can only find the exact genetic answer in maybe about as many as 20% of patients with hereditary aneurysm syndromes. So for the rest of those families, it's not that they don't have a genetic cause. It's just that maybe that precise gene that is causing it in that family hasn't been discovered yet. But because we know those conditions can be heritable and give risk to family, for a patient like that, we may not have a genetic test to offer to their at-risk relatives, but we would say, you know what, the genetic test didn't find the answer, but your relatives are still at increased risk, so we would recommend the following clinical screening regimen. And then we would deliver that to the patient to be able to share with their at-risk family members so that they could really get that clinical cascade screening.
And one thing you mentioned there that I wanted to highlight was that someone could have a genetic mutation that, again, is being able to be passed through a family, and we have not identified it yet. So that makes it even more important for patients to stay in contact with their genetic counselor every few years. I don't know exactly how many, but to recheck in with their genetic counselor and say, hey, is there any new testing that I can do to see if now we can identify it?
That's exactly right. Every patient, that we would see in our clinic, we would inform them if their genetic testing was negative or maybe even found a variant of uncertain significance that we weren't really sure whether it was truly the disease-causing variant in their family or not. We would say, you know what, check back with us in a year. Or, if you're a little bit more anxious, check back in with us more frequently. And we kind of always gave that number of a year just to call us back, see if there was any more powerful genetic testing that could be available to them. And really, in the course of my career, I've seen cardiovascular genetic testing transform from the really early days where it was mainly research laboratories that were able to test maybe a handful of genes to these larger, more extensive tests that really might have the power to find more information. And also with large data sharing initiatives like ClinGen and ClinVar, where laboratories are being asked to deposit their genetic testing classifications so that really, the whole world would be able to have access to this really important information. We're seeing the capability to have more and more genetic tests have their interpretation be, kind of to have really much more solid evidence behind it and to share that information among patients, because you might have a patient in Columbus, Ohio, where I live, who might have a genetic testing report that tells them their variant is of uncertain significance, but then maybe you have a patient across, the world in Australia who may come back with that same exact variant. And as you can continue to build more data surrounding that information, you can hopefully communicate back to those patients, okay, we're seeing this in more people now. We're seeing this in more people who have your condition, and it's also tracking with affected people in the family. So this really does appear to be the true disease-causing gene mutation that is, the cause. And then that opens up the whole new world of getting an official genetic diagnosis and being able to have that cascade testing be pursued. So it's really important that, I like to say genetic counseling, it's not just a one-time conversation. It really is something where that genetic counselor can help serve as a continued resource to you, whether it be for updated genetic testing information or whether it be to check back in to hopefully have other family members come back in and get tested too.
And for those other family members being tested, should children be tested or should they wait until they're adults? Does this differ in the cardiovascular kind of subfield compared to other different subfields like cancer or pediatrics? Like, how do you guys view this, and what is your kind of guidelines for that?
Mm-hmm. It really does. It really does. Because many of these conditions can present in childhood. And also because for many of these conditions, the preventive medications can be started in childhood. So again, I'll use a couple examples like FH and long QT syndrome. If you have an affected child, that really is important to know, because for FH, statin medication can begin as young as age 8. For long QT syndrome, likewise, beta blocker medication can be initiated at younger ages. And we know that for some of these conditions, like long QT syndrome especially, the adolescence period is a very high-risk period. So really, the parents and the child need to have the benefit of this information as early as possible to really give them the opportunity to initiate these risk-reducing medications to help shape whether they may be in intense competitive endurance athletics or not. And so it really is, within cardiovascular genetics, something that we do talk about, and pediatric cardiovascular genetic counselors are really important so that they can be working at Children's Hospital and with pediatricians to bring that care to these children.
And so early is really the best. As soon as you can kind of get in to see a genetic counselor, if you have this family history, that's really the best scenario.
It is. It's not something to wait around on. Seeing that family history, it's important to act on, especially if you have people who are parents. It's important for them to act on for their own health, but also truly for their children.
And one more question I have before we end the show is, what is the current system for notifying at-risk relatives of patients that you see? So say you see a patient and maybe they're not in contact with their siblings, or how is your role in this, and what is the expectation that you will reach out, or do you not? How does this really work in the field?
It's a great question, and one that I'm really passionate about. And actually, I had the opportunity to co-chair a pre-conference symposium at last fall's National Society of Genetic Counselors Education Conference on this exact topic, and kind of talking about cascade testing and family communication and this notion of quote unquote direct contact of at-risk relatives. Direct contact of at-risk relatives is not the standard of care, and it really needs to be a case-by-case situation with each patient and family you counsel, especially for privacy and confidentiality reasons. But within the context of certain families, genetic counselors are sometimes asked by their patient to directly speak with at-risk relatives, with their permission or with their even written consent, because it can be challenging to share this complex medical information with at-risk relatives. There's also been a lot of research that has shown that probans, which are the initial person in the family to be diagnosed or come to medical attention, feel that they have a lack of authority in really being able to be viewed as kind of the authoritative communicator of this information in the family, maybe because they're not a medical practitioner. They feel like their relatives may not necessarily receive this information from them and then be able to act on it. So many genetic counselors provide helpful tools to the probans to assist them in family communication, whether it be something called a Dear Family letter, or a hard copy of that, or something that could be shared in email, or share disease-specific brochures or printouts that could be given to the proban to then pass on to their at-risk relatives. There are also a few internet tools that have been developed, especially in the world of cancer genetics, not as much in the world of cardiovascular genetics. And then, some patients may be working with different types of social media tools. I remember very well a patient of mine who was a teenager with long QT syndrome, and she tested positive, and her grandfather lived in Europe, and the way that she informed him of his risk was via Facebook, and it worked. So it really is not a one-size-fits-all approach. It's, hey, what could work for this proban, for this family? But I will say that I'm very interested in, continuing to see, would direct contact be something that would be useful and accepted for some patients and families? Because again, there has been research that shows that probans welcome this greater assistance from the clinical genetics service to really assist them in this process. So it's very complex, and every family is different. Some families have great communication about this types of information. Some, struggle with it much more. And so I think as genetic counselors, we really need to be having the conversations with each patient about what the family dynamics are, so that we can figure out what is the best method that hopefully will have the best success to get this information into as many at-risk family members as possible. And if probans are open to their genetic counselor having a direct conversation with at-risk relatives, that can be an option.
And so with that, I think we have to end the show because we're out of time. But thank you so much for, coming on the program and really educating us on cardiovascular genetic counseling and testing, and giving us a glimpse into what patients can expect coming into the office and meeting with someone and kind of going over this and what maybe should bring them into the office. So thanks so much for coming on the show.
You're very welcome. Thanks again.
And so for patients that do want to find a genetic counselor, you can go to aboutgeneticcounselors.com, and there is a Find a Genetic Counselor feature on there where you can find one in your local area or through the phone. So highly recommend that, and that's from NSGC. And if you are looking for more information, you can go on Twitter at Amy Sturm to follow her on Twitter. She's very active, especially in the GC chat community. And if you're looking for more information on the show or to listen to all the episodes, you can go to dnapodcast.com, at DNA Podcast on Twitter, at DNA Radio on Instagram, and you can email in at info@dnapodcast for any questions you have about today's show or any other episodes. So thanks for listening, guys, and join me next week to learn and discover new advances in the world of genetics.
How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, genes of you, and they're all made of DNA. We're all made of the same chemical DNA.